And thank you for the opportunity to be here with you. If you are happy, we can have question and answer at the end. But if you want, you can interrupt me. If it's so excited what I'm telling you, you can say, hey, just explain that. Okay. Yes, this is my work in El Salvador since 2007. I moved to the United States after working for 5 years with the USAID, managing infectious diseases. I moved in at the December 2004, and since then I have been working as a clinical associate professor at the College of Health, University of Florida. But my heart is also in El Salvador, so I always bring students, and we have a program there. And this is part of what we are doing in El Salvador. We are going to talk about all these topics in El Salvador, trying to explain you what is the situation there and how health determinants are shaping the situation right now. El Salvador, as you can see here, is the tiniest country in the American continent and very high in population density. We have a very small territory, 21,000, population 6.3 millions. Another 3 millions are here in the United States, including me. And population density 298, female 52, 47 males. 48% of the population is under 30 years of age. So we are really, life expectancy for females 74.5, for males 68.3. The illiteracy rate 13.7%, but this is national level. You will see later what is the situation in the town I am working. Extreme poverty 11.2%. Urban poverty, 33%, and 9% of them live in extreme poverty. But the poverty in rural areas is 43.2%. Some of them, 15% of them live in extreme poverty. So what happened in El Salvador in the recent historical and socio-political context, especially in Morazán, where we work, and the borders with Honduras, El Salvador lived a terrible civil war that killed more than 80,000 people in the 80s. So the war really started in the 70s when I was in the first year of medical career, but it was officially recognized as a civil war in the 81 and lasted until 92. So Perquin, Morazán was considered the stronghold for the guerrillas, so they were very strong over there. And for that reason, after the civil war finished, because the ruling party was the same, they neglected the area in every social situation. So in the area we are working, El Mozote is located. It's a village in which in one day, in 1981, 1,200 people were killed. 100%, no, 99% of all inhabitants were killed. Only one person survived, and they were killed, complete families. So this is a monument here in which all the family names are written. And it's a monument that the United Nations built after the peace accord were signed. So here is the map of the Morazán, and around is Honduras. So they live in the border with Honduras, they share the border. But in 92, after the peace agreement was signed, the government of Honduras fight to get a piece of land that belonged to El Salvador. So Honduras is 6 times bigger, but they want another piece from El Salvador. And according to historical paper, they were approved, so the land went to Honduras. But 12,000 Salvadorians who live there now enjoy double nationality. The problem is that since that agreement occurred, Honduras government removed all health facilities, schools, and everything from the area, including the facilities that were serving their own Honduras people. So in 2009, for the first time, a new government came, because the previous 20 years, the same government that ruled during the Civil War were established. So in 2009, the former revolutionary forces became to power. So they are in the presidential, and the second round was in just this month, 2014. In 2010, they launched a health reform that focused on family, community health, with the stakeholders' participation on an integrated health services. That was 2010. The maternal mortality in El Salvador has been decreased, as you can see there in these figures. But the main causes of mortality are preventable. Postpartum hemorrhage, hypertensive disease during pregnancy, sepsis, and 24% of mortality occur in adolescents. Infant mortality under 5, 9.3%, under 1, 8%, neonatal 5%, and the causes again are preventable here. See, this picture shows part of the monument of El Mozote, and here you can read all the names of children under 12. We have children who died with a bullet here that were 14 days age. So it was, it's a monument now that everyone go there and visit. And the other pictures are my students working in the communities there. So what happened in 2007, we went there and we decided to choose one place to work because we want to create sustainable solution. We don't want to go one day to one village, the other day to another village, because that happened with other universities and you never see changes. So we decided to get one single community, work with them and follow them, trying to empower and to create public health interventions. So we try to look for the poorest community in the area, and the poorest canton, which is a village, the poorest health indicators, and the disparities that still continue, because what I was telling you, that was 2007 before the other government came. So we chose El Limón, Morazán department, in which this is the kind of housing that live there. Sometimes it's very cold, and you can imagine this world like this and also it's very dusty. So these pictures is what we found in almost every household. You can see here, this is the kitchen, and this is the terrible conditions in the whole village. It was rubbish everywhere, and the children were having problems. Look at the malnourished cow, because there is no water, nothing in the area for them. So animals also have health problems. And the department of Morazán, as I say, is before was the stronghold of the guerrilla. 2,000 people. Illiteracy rate is over 20%. 25% of the children of mothers without formal education present chronic malnutrition. The average length of school is 3.4 years. 94.6% of residents live in poverty. Adolescent pregnancy is 48%. Okay, so this area, if you compare with other areas in El Salvador, where the majority of the 3 million people comes to the United States, are different because they are so poor that they cannot afford to pay for the coyote that bring them to here. So it's very little people sending remittances there, but there are, but it's very little. we visit several communities in the region, including in the Honduras area. When we were to this community, we were talking in that particular house with the family of 5, 3 children and the couple. And what we saw was the tortilla incident. First of all, the doctor in the area showed us this study that he done, in which he wanted us to understand that dogs are competing for food with the people. He made this calculation of the corn production, annual corn production, in which dogs eat 27% of the corn production, which total 1.3 million a year. So we were okay, you know, but when we were there in that particular house, so this was you can see this is the kitchen. They have 2 tortillas for the whole family, that lunch. And as you can see all the hygiene conditions also. And suddenly this poor dog, very malnourished dog, came and stole 1 tortilla and ran away. So that was shocking for everybody, even for the family, of course. So we decided that, so this is the picture later. So we decided to stay there in that particular area, not only because of the tortilla incident, but because the terrible conditions, especially the hygiene condition, malnourished, and everything. So this is the population in the particular area of Morazán. You can see here, it's a little younger than the national average for 2010. And at that moment in 2010, Morazán, El Salvador has 14 departments. Morazán was the department with very, very few doctors and nurses. Human resources were very poor. So what we did, we conduct, first of all, a community assessment in the north of Morazán, Perquin, Torola, San Fernando, Arambala, and in the border with Honduras. We went and met with Nahuatl, El Zancudo, Sabanetas. We conducted the reciprocity model, and we have initial partners, Minister of Health, local level, and the mayor of 3 municipalities, the police, and community leaders. Those were our initial partners in the first assessment. We conducted a Minister of Health family survey in 2008 in that particular region, because although the Minister of Health had the survey for national level, they were not able to conduct the survey because they don't have people working with them. So we helped and we did it, and it helped us also because it provided the data that we needed. We also did GPS mapping of potential water sources and have a proposal to someone to help with the water sources. We interview and evaluate every member of the family. This is one of the mother and child living in the area. So in the assessment, of course, we conduct literature review that was available for that area, the focus group, in which we have a focus group with community residents. Here, husband and partners, because women were telling us, oh, I want to go to the doctor, but my husband doesn't allow me. So, and this is something that one of the husbands say, I don't want my wife to go to the hospital to deliver the baby because she needs to cook me and take care of my other children while I am working in the field. So that was the thinking. So, and then in the discussion and in the behavior change interventions, the discussion was, what happened if she died? You know, what happened with the other children? So they started thinking and thinking. We also have a focus group with health providers, plus the Minister of Health survey. So this is some of the findings. 97% of the population, children and adults, has oral health problems. So 97% of them, as you can see here, environmental health, apart from the picture that you saw, there was something that drew our attention. It was the time of the avian flu, H1N1, and people believe that matching all batteries in recipient where the chicken drink, they will prevent avian flu in the chickens. So, and that created a terrible situation in the whole village because children were matching the batteries and putting in the recipient. And then the chicken were drinking. And I asked them, are you eating the chicken? They said, no, these are our bank account. When a child is sick, we go to the market to sell the chicken, and then we can have money to pay for our medicines and our transportation. So when that happened, and of course, nutrition problem, chronic diseases, infectious diseases, everything, helminths, chagas, including. But also, we saw something that occurred not only in that particular place, but also in the north of Morazán and the border with Honduras. Maternal health issues were very high. And so we decided, with the partnership with the Minister of Health, to work in Morazán, in 8 municipalities of the north of Morazán that are covered by 8 clinics of the Minister of Health, and also in Honduras with 4 municipalities that has 1 clinic in the very far from the border. So we then started to create a large partnership because we need more partners. So International University that also come to the region, we partner with them. High school children, they receive training. They were organized as a health promoters for their own community in areas of maternal health, in areas of hygiene, etc. All the issues that we found. The governor of Morazán is a very important player, especially the new government with the new, the government that came in 2009. So he used to be a priest and during the war, and now he married later and he became a governor. But he was a very important figure during the Civil War because there were 2 priests and he was one. And he's really, really committed to the community. Here you can see in the picture of the high school children. They were amazed by one of our students, and they were talking about sexual education. So they have a program to prevent adolescent pregnancy and other issues. We also work with the Minister of Health at local level. You can see here a team of nurses and other health professions that were able to come with us outside the clinic. We proposed, let's go to the community. Let's go together in this particular community. So they came with us. Churches, we have Catholic Church and Evangelical. And that was very nice because now the priests and the pastors are talking about health and, for example, are asking their people to bring food for the maternal waiting facility that I am going to explain you. So you can see in the mass all the little children going to communion with a bag of beans, for example, or vegetable. And they gather the food and they bring it to the facility for pregnant women. We also have the kindergarten because we want to work with them since oral health, hygiene condition, etc. The municipalities of all the places, the University of El Salvador, because until that time they never went there. They have the internship for medical school or even for public health master degree in areas near the capital city. So we want us to bring them because we want sustainable solution. When we are not there, they should continue. And then we return and they should continue and they are working together with us. This is the only way. Otherwise, we return the next year or semester and the situation will be the same. Also, the Minister of Health, at central level, after we conducted the assessment, we request a visit to the Minister of Health, and he received us, our delegation. So we say our students dress up because we are going to see the minister and we are going to explain the whole situation here. So they were, very, very happy to see us. Oh, we are doing this, we are doing that. And then my student presented, and they feel like a shame because, they don't have water, or they don't have electricity, something like that. So 3 months later, they put water in the community. And the next year, the community has electricity also. So they were pushing together because the next year, we brought the community with us to make them able to advocate for themselves, and at the same time, they are getting skills to negotiate for their own purpose. And also, the Honduras clinic. You can see an ambulance there. When they manage, the Honduras people in the most remote area, when they manage to get to the one clinic they have there, the clinic just cross the border and come to El Salvador, to the clinic in El Salvador, and to the maternal facility. So they don't go to a Honduras facility because number one is closer, number two is totally free, with the solidarity that the Minister of Health has, and women are really treated like everybody, and we are also, I can say, saving lives. So this is the community working together in a community forum. So we implement the health belief model in which we have individual perception, perceived susceptibility to have a premature stillbirth baby due to the lack of antenatal care, poverty, and access to a hospital, perceived severity during childbirth or death of the baby, and the modified factor, we were sure that we can modify some of the gender issues to make the man to support the wife to go and to realize that it is for their own interest and the interest of the family that the woman have to come to this maternal facility. Lack of education. So we work with the University of El Salvador, and now they are establishing a campus in the area, a campus of the University of El Salvador that will give with the private sector scholarships for children coming from after high school, and they will be graduated in ecotourism, agriculture, microenterprise, etc. And we want also to start a public health program, certificate for the student. Unemployment, the municipalities and the decision makers at the regional level are urging the central level to give them money from the Millennium Fund that United States is providing to the new government. They gave $800 million for human development in that particular area. So they are going to establish microenterprise and training, etc. So social, psychological support is important, family support, counseling, and then perceived threat of hospitalization and death, and cues to action, counsel from provider, modeling by peer, expression of relevant by loved ones. And then we have the likelihood of action, perceived benefits, increase in life expectancy, healthy baby, other children will not be orphaned, minors perceived barrier, separated from family, in an environment that I don't know, how they are going to treat me, for example, who will take care of the rest of the children, complicity of the health system, because after being in a facility, I'm going to have my baby in a hospital, I've never been in a hospital, etc. But those likelihood of action could create the likelihood of seeking attention in the maternal waiting home. That was the facility. We also implement the theory of freeing. I don't know if you are familiar with that. It was implemented and proposed by Pablo Freire from Brazil. It's an educational theory in which he said people are free if they are educated and if they are mobilized. So there are three phases: the listening phase, community dialogue, and the cues to action, collective action together with the stakeholders. So we went to the community when we go with the student. As you can see here, this is local Minister of Health and a student from the University of El Salvador with our student. We conduct house by house visit in which everyone has, screening, and this is the dentist taking. So what happened here, because everybody has terrible oral problems, so most of the extraction have to be done very quickly. So all the children were terrified and with fear. Oh, the doctor are going to see me. Even the adults that you can see here, he's looking inside how the how the performance is doing. So we decided, and my student decided, to establish the beauty salon, because all the children were amazed about the braid that our African American girl has. They never see that kind of hair treatment, and they want all of them have the same braid. So the student established that, and it was so amazed because they forgot that they have to go to the dentist immediately. And the mothers the next day say, oh, she wants to sleep sitting because she doesn't want to dissolve the braid. So that became very, very nice. As the anthropologist said, maybe in the future, people will see how they get to this new style. So we conduct house-to-house visit. And you can see here the terrain is very hard. Here we conduct medical examination to the community. We have optometries also with providing glasses for the community. And this is us inside a house, a home in which the students are giving face-to-face interventions. So we also, this is the situation outside as we founded in 2007. So we create two committees, one for the children and one for the adults, of hygiene, environmental hygiene. So the children are having present, they clean the complete village, and the adults continue giving talks. They are trained, so they continue giving the behavior interventions with the community, and the children who also receive intervention at the school and kindergarten, they are eager to participate in these interventions. We also train health workers here. All of these are medical directors of the 8 clinics that exist. So we train them in all these areas: behavior change theories, planning model, Chagas control and prevention, because it's very high in that particular region, other infectious diseases, chronic disease control and prevention, maternal health, community health, public health ethics, environmental health, and healthy school, healthy communities. Public health ethics for me was most important to talk about global health ethics, because there were a lot of university or groups coming, and not all of them perform ethically. So I want them to be aware that if someone come and take blood samples for Chagas and never return the result, this is not correct. I want them to know that they have to be partners and co-investigator, co-PIs, etc., etc. So, and then I also train the central level to allow them to create the rules and regulation that we need to observe. We also train here, this is a community forum with parents and teachers at the school. Here is the high school, and we also, of course, train our students. They receive all the information, the epidemiological situation, the opportunities and constraints that they have in the community. So here, our student giving advice with the optometrists. This is how they receive. And here, it was the last day in the community, and the governor is invited to come with us. He needs to come from his office and be with us, and the student provide the result of the all problem they have. And so, and he's very nice. He say, okay, next time you come, you will have this and that and that. So it's nice. He was the one that after this intervention went with us to meet the president of the University of El Salvador, and we convinced them to develop a new campus in the area, which is nice for the children who are getting out of school. So this is the program for reducing maternal mortality. This facility is called the Maternal Waiting Home to reduce maternal mortality and child in Perquin, Morazán. The Hogar o de Espera Materna is a community supported facility. As I mentioned before, even the priest is requesting food because everything is free for the mothers here. So pregnant women come before their due date, go to the hospital, and then enjoy professional assistance during childbirth. The facility was built by the U.S. Army, which was a very nice demonstration of partnership with the U.S. government. This is the map where the regional area served by the Maternal Waiting Home. So the color map is the north of Morazán with all these municipalities. Here is the Torola municipality where El Limón is located, and here is Perquin where the maternal facility is located. All here around is Honduras border. So women come for 30 to 33 days. They stay there. 2 weeks before, 2 weeks after. They have daily checkup by doctors, childbirth care, postnatal care, promoting breastfeeding for at least 6 months, diet and nutrition, intimate partner violence is very important, and prevention management, women empowerment, family planning and birth spacing, vegetable garden that they can crop even in areas where water is difficult, childbirth at hospital, postpartum period, they come and they receive prevention for neonatal infection and immunizations. So this is the number of people that have come. As you can see here, the largest number come from Honduras. And this is, the second is the Salvadorian Hondurans who live in the former land from El Salvador. And then Torola, our community. And then you can see coming from everywhere. So here is the facility inside. Women are cooking their own food. They have a very nice clinic. Women's develop handicraft and toy for the babies, and they express the love for the babies. So every woman has a room like this, in which the women can sleep here or here, and the other children, they receive the other children. When they come from very remote area, come with the children. We don't want you to, to die, and if you don't have someone, because the male is, in the field, so they come with the children, and the children stay there when the children come with the other baby. So they feed the children and everything. And as you can see, we have protection for dengue fever, for mosquito, to prevent dengue fever in case they have. And they have constant, in those 30 days, they have constant interventions of prevention and control and everything. Vegetable garden, this is hydroponic gardens in which they can manage the water, that they have a shortage of water. So we help with that, and then we look for an agronomist to come the whole year to help them from the University of El Salvador. So these are the numbers of pregnant women who came in 2011, 2012, so the numbers are increasing, and these are the figure for new babies. And this is the maternal mortality. So 2007, it was 34 per 1,000, and since 2010, 000. And this is a great achievement, especially for everybody. There was a case in which the woman had the baby in Honduras, and after she was complicated with sepsis and everything, they brought it to this facility, and from here they sent it to San Miguel, and from San Miguel, which is 4 hours, they sent the woman in a helicopter to San Salvador, and she died in the helicopter. And everything paid by the Salvadorian government. But what happened, nobody wanted to record the death of the woman. The Honduras said, no, it's not our death, because they were punished by their government. But anyway, so at the end, it was in San Salvador that the death was recorded because of the helicopter. It was very sad, but at the same time, it shows you how the pressure it is over the people who want to achieve zero maternal mortality. But this is a great, great success. And what happened then, this is the Hogar de Espera Materna in Perquin, the #1 in the whole country. After this great achievement, the government has decided to open Hogar de Espera Materna in the whole country. So that served as a model, and now other countries in Honduras, Nicaragua are requesting technical assistance and advice to create this model. The government opened a new health reform in which transparency is free of cost, 100% universal coverage, solidarity with communities like Honduras, for example, commitment, universality for everyone, equity. Sorry, it's not as good as I like to do this. Social participation and multi-sectoral. So the feeling that you need anthropologists, doctors, you need psychologists, you need physical therapists, you need etc. is very important, and work together in partnership. So now you can see here the first graphic I showed you, the density of human resources for health working in Morazán in 2010 was 4.20, the lowest. Now they increased to 13.41. So there is a political will also. So these are elements of the new sexual and reproductive health. I don't want to stay here anymore because we don't have time, but human rights and social justice approaches is important, regardless of sexual orientation, race and ethnicity, physical disabilities, and socioeconomic status. This is important because El Salvador has been very conservative in terms of sexual orientation, gender equity, life cycle approach, etc. So approach is based on social determinants. So this is the national level, 2009, 2012, integrated comprehensive network for antenatal care. So the conclusion, political will is very important at the local level and also at national level, as you can see with the health reform, etc. Multi-level partnership is so important. It's crucial because, for example, a woman who is in the other border, there is no transportation there. So they call to someone that has telephone, and there is a list of people that has transportation, private person. They go and pick the woman and bring it. So it's important to engage multi-level partnership to address health determinants, community stakeholder, building trust and partnership, and also solidarity is very important. So, China. China also has problem in maternal health. We have, this is in general, the ratio is difficult because China is very big, but these are the figures from UNICEF in which we know that we can also create alternative. Socioeconomic disparities exist in access, service, and utilization. Rural areas are in the most disadvantaged, receiving antenatal and postpartum care. Ethnic minorities also in China have a higher rate of home birth and maternal mortality. Migrants versus permanent resident in urban areas also has disparities there if we talk about maternal mortality. Restriction of the number of person preference in China culture also create an authorized pregnancy, and having achieved a son was reduce the likelihood of women accessing maternal care. So I took this from the literature. So I think we can model some of these. Although I presented maternal health, but I have been working in almost everything. Water and sanitation, infectious diseases, etc. But we can take the model. The model is, I think, the most important. For example, when I was working with tuberculosis, managing $9 million TB USAID, what we did was the same. We organized the community. We organized even the street vendor of alcohol that were supplying the homeless. So we trained them how to detect and refer TB patients, for example. And El Salvador became a model for that. So we can use this teaching strategy with field experience, with a strong theoretical base, knowledge of health determinants that check the current health status, health and illness information at the country and community level, knowledge of health policy, partnerships from family up to the Minister of Health level, and international institutions, team of students with different skills, primary health care, environmental studies, language and culture and competence, and short-term experience, or internship, or long-term experience. So my teaching has been grounded in practice, and these are the list of some of the experience I have that helped me to teach at the University of Florida what I am teaching, global health, program planning, etc. And so, and this is the community with the healthy babies. This picture is a Hmong community, and you can see here healthy babies and a smiling mother. And that's it. Thank you.